Welcome back. This is Dr. Timothy Collins with the Division of Headache Medicine at Duke University Department of Neurology. This is part 2 of our 3-part course on headache and head pain for primary care providers. We're going to spend the next few minutes talking about imaging and diagnostic testing in patients with headache disorders. In general, patients with a stable history of headaches, having had their headaches with no significant change in headache frequency and severity for more than a year, who do not have any concerning features or red flags, do not require diagnostic imaging. This is from the American Headache Society's evidence-based guidelines for headache care, published this year, 2020, in February. This is a fairly standard recommendation amongst headache clinics and neurologists, and can be helpful in decreasing the number of imaging tests that headache patients with stable symptoms undergo. When we consider imaging in patients with headache disorders, we're really looking for a number of concerning features, or what's called red flags, in their history and physical examination. Clearly, any focal neurologic symptoms or signs such as focal weakness, loss of consciousness, or abrupt onset of ataxia are reasons to get imaging in a patient with a headache disorder. Abrupt onset of headache, consistent with thunderclap headache, which is more typical in patients presenting with a ruptured intracranial aneurysm, also needs imaging, often urgently. And these patients really should be considered for some sort of vessel imaging, whether it's a CT arteriogram or an MR arteriogram. Patients with headache and fever typically need imaging, as well as further diagnostic testing to ensure that they don't have meningitis or an intracranial abscess. Patients with papilledema always require imaging. This, of course, can be seen in patients with increased intracranial pressure from tumors or obstructive hydrocephalus, but can also be seen in rare headache disorder called pseudotumor cerebri. These patients rarely present to the emergency room, but are often referred to our practice from ophthalmology, having had an abnormal eye examination. Patients with a new onset headache and any history of cancer in the past should strongly be considered for imaging to ensure they do not have any metastatic disease causing their headaches. Patients that are immunocompromised from either medical treatments for connective tissue or autoimmune disorders, chemotherapy, or infection with HIV should also be considered for imaging if they have a new onset headache, whether or not they're being treated for their immunosuppression. Patients with new onset headaches in the previous 6 months, especially if they have a progressive increase in headache frequency, should be considered for imaging to rule out intracranial mass. We often consider imaging patients in rare headache disorders such as cluster headache and trigeminal neuralgia, as a high frequency of these patients are found to have intracranial pathology as a cause for their headaches. In general, all patients with trigeminal neuralgia need to be imaged once in the course of their disease to ensure they don't have a posterior fossa mass or demyelinating disease as a cause for their symptoms. Onset of headaches after the age of 50 is extremely uncommon, so patients with new onset headache after the age of 50 should be considered for imaging. Atypical headaches that are often associated with intracranial disease, such as cough headache, patients with a marked positional or postural component to their headaches, or patients with repeated thunderclap headaches, all should be strongly considered for imaging. Some patients with exertional headaches, especially if they're triggered by very specific exercises or exertion, should also be considered for imaging. Imaging modality is important if we're imaging patients in an urgent setting, such as in the emergency room or after trauma. CT scan of the brain is much more sensitive to finding intracranial hemorrhage than MRI scan. On the other hand, if we're imaging patients in the outpatient setting and our primary concerns are tumors or demyelinating disease or remote history of cerebrovascular disease, MRI scan of the brain with and without contrast is the preferred test. In particular, if you can specify your concerns or what you're specifically looking for, such as demyelinating disease or intracranial mass, the approval process with third-party insurance may be easier. Lumbar puncture is rarely performed for the diagnosis of idiopathic headache disorders such as migraine headache and tension headaches. It may be appropriate in patients that have the worst headache of their life or a thunderclap headache to ensure that they don't have meningitis or subarachnoid hemorrhage. It's also the main diagnostic test in patients that are presenting with papilledema in normal imaging studies in order to determine if their CSF pressure is elevated to diagnose idiopathic intracranial hypertension.